Our next speaker, I believe, is liver will be next. Dr. Arvind Murali will teach us about liver stuff.
Hey, good evening, everyone. So we'll take a break from GI, move on to hepatology. So the first section would be on autoimmune liver diseases, more specifically on primary biliary cholangitis. So the first abstract is on the efficacy and safety of seladelpar in patients with primary biliary cholangitis in the ASSURE study. These are the interim results. Seladelpar is a potent and selective PPAR delta agonist, has been shown to be superior to placebo in normalization of alkaline phosphatase and improvement in pruritus in patients with PBC. In the ongoing international phase 3 study, patients with prior participation in seladelpar PBC studies received open-label seladelpar. PBC patients were eligible if they had an intolerance or inadequate response to UDCA and previously participated in a seladelpar PBC study. All patients received open-label seladelpar 10 mg once a day. Biochemical endpoints included a composite response of alkaline phosphatase less than or equal to 1.67 times the upper limit of normal, or an absolute alkaline phosphatase decrease greater than 15%, and a total bilirubin less than the upper limit of normal. Other endpoints included normalization of alkaline phosphatase and changes from baseline in alkaline phosphatase, GGT, ALT, and total bilirubin through month 12. Of the 174 patients, 94% were females. Mean age was 58.4. 85% of these patients had reached 12 months of treatment. The mean alkaline phosphatase was 270 and total bilirubin was 0.75. Majority of these patients were concurrently treated with UDCA and 19% had cirrhosis. But 70% of patients achieved the composite response endpoint with seladelpar 10 mg. Alkaline phosphatase normalization was seen in 37.2% patients. The mean alkaline phosphatase change was 44.4%. Seladelpar also lowered GGT, ALT, and total bilirubin by 36%, 25%, and 9% from baseline, respectively. No treatment-related serious adverse events were noted. Discontinuation rate was 4%. To conclude, in the open-label phase 3 study, seladelpar led to clinically meaningful improvements in markers of cholestasis and liver injury, including high rates of alkaline phosphatase normalization. Our next abstract is on the effect of obeticholic acid on normalization of ALT and AST. It's a sub-analysis of the phase 3 POISE trial in PBC. Elevated levels of ALT and AST are associated with the risk of poor clinical outcomes, including hepatic decompensation, liver transplant, or death in patients with PBC. Obeticholic acid is a selective farnesenoid X receptor agonist that received accelerated approval for PBC based on improvement in alkaline phosphatase and total bilirubin in the POISE randomized double-blind placebo-controlled phase 3 study. PBC patients who could not tolerate or had incomplete response to first-line UDCA were randomized at 1:1:1 to receive placebo, titration of obeticholic acid, they started 5 mg and increased to 10 mg, or OCA 10 mg daily for 1 year. Serum ALT and AST levels were assessed at all visits. The primary endpoint of the study was alkaline phosphatase less than or equal to 1.67 times the upper limit of normal, with greater than or equal to 15% reduction from baseline, and a total bilirubin less than or equal to upper limit of normal. The association between OCA treatment and normalization of ALT or AST at month 12 was evaluated. Overall, 90% of patients had elevated ALT and AST levels at baseline. When you look at ALT, normalization of ALT was 10% in the placebo arm and 29% and 33% in the titration arm and in the OCA 10 mg arm, respectively. Similarly, for AST, normalization of AST was 10% in the placebo, 23% and 30% in the OCA titration and 10 mg arms, and the p-value was significant for both. Obeticholic acid normalized ALT and AST levels in a higher proportion of patients as compared to placebo. So to conclude, these data suggest that FXR agonism with obeticholic acid can reduce ALT and AST levels below thresholds that are prognostic for poor clinical outcomes. Metabolic outcomes and key efficacy data from a phase 2 trial evaluating combination of obeticholic acid and bezafibrate in patients with PBC. Obeticholic acid is indicated as a second-line treatment for PBC patients who have an inadequate response or intolerance to UDCA. Bezafibrate is a pan-agonist of the peroxisome proliferator activated receptors. It has also been shown to benefit patients with PBC. In this study, patients were randomized 1:1:1:1, 4 groups, to receive either oral once daily bezafibrate 200 milligram immediate release or bezafibrate 400 milligram sustained release, or a combination of obeticholic acid and bezafibrate 200 milligram immediate release, or a combination of obeticholic acid and bezafibrate 400 milligram sustained release for 12 weeks. Metabolic outcomes, including mean % change from baseline in total cholesterol, HDL, LDL, and rate of normalization of total cholesterol and LDL at week 12 was measured. Mean % change from baseline and rate of normalization of alkaline phosphatase at week 12 was also recorded. A total of 75 patients were evaluated. There were 19 patients in 3 arms and 18 patients in the OCA bezafibrate 400 milligram arm. The combination treatment of obeticholic acid and bezafibrate 400 milligram induced the greatest % change from baseline in total cholesterol, HDL, and LDL at week 12. Highest rate of normalization of total cholesterol occurred in the combination arms, obeticholic acid and bezafibrate 200, 57.9%, and obeticholic acid, bezafibrate 400, 55.6%, and that of LDL occurred with obeticholic acid and bezafibrate 400 milligram arms. For alkaline phosphatase, obeticholic acid and bezafibrate 400 induced the greatest % change from baseline, and this was statistically significant. It also led to a rate of normalization at 66.7% at week 12. To conclude, short-term administration of obeticholic acid and bezafibrate has therapeutic potential to normalize key biomarkers of PBC-related liver damage that have been correlated with improved decompensation-free survival. Obeticholic acid and bezafibrate combination has an acceptable metabolic profile with positive impact on cholesterol and LDL. No liver talk will be complete without talking about fatty liver disease just before dinner is served. So the first abstract is the association of glucagon-like peptide 1 agonists with cirrhosis and hepatocellular cancer in metabolic dysfunction-associated steatotic liver disease, or MASLD. So recent studies show that GLP-1 agonists are effective in improving liver inflammation in MASLD. Whether these treatments prevent progression of liver disease and liver cancer remains unknown. This was a retrospective cohort study of adult patients with type 2 diabetes mellitus and concomitant MASLD in the United States Veterans Affairs Healthcare System. Patients who initiated GLP-1 were identified, and the date of first prescription was used as the index date for follow-up. Each user was matched with up to 50 patients who were not prescribed GLP-1. Propensity score matching was used to balance potential confounders, and outcome was the time from index date to either cirrhosis or liver cancer, whichever occurred first. Cause-specific Cox proportional hazards model was used to study the causal effect of GLP-1. 23,670 patients who used either liraglutide, semaglutide, or both agents, and 169,000 matched non-users were identified. The median follow-up was 20 months. Annual incidence rate of cirrhosis or liver cancer was 0.82% among GLP-1 users and 2.3% among non-users. The adjusted hazard ratio was 0.29. GLP-1 agonists were also associated with a reduced risk of liver cancer, with an annual incidence of 0.02% versus 0.05%, the adjusted hazard ratio being 0.36. To conclude, in a nationwide study of patients with MASLD and type 2 diabetes mellitus, use of semaglutide or liraglutide was associated with a significantly lower risk of progression to cirrhosis or liver cancer than no use. Effect of empagliflozin on liver fat in MASLD patients without diabetes mellitus, a randomized, double-blind, placebo-controlled trial. The effects of sodium glucose cotransporter 2 inhibitors in MASLD patients without diabetes mellitus is unknown. This was an investigator-initiated, double-blind, randomized, placebo-controlled trial recruiting adult subjects from the community between March 2021 and April 2022. Eligible subjects had magnetic resonance imaging proton density fat fraction, also called the MRI-PDFF, greater than or equal to 5%, but without diabetes mellitus. They were randomly allocated to receive empagliflozin 10 mg daily or placebo for 52 weeks. The primary outcome was a difference in the changes of MRI-PDFF between two groups at the end of treatment. Secondary outcome was a resolution of hepatic steatosis and changes of anthropometric and laboratory parameters at the end of treatment. 98 subjects were included. Mean age was 55.7 years, 54% were males. At the end of treatment, the empagliflozin group had a greater drop in median MRI-PDFF than the placebo group, statistically significant p-value, with a trend to resolution of hepatic steatosis, 45% versus 29%. Empagliflozin group had a greater drop in body weight, statistically significant, weight circumference, and fasting glucose compared with placebo group. To conclude, treatment with empagliflozin for 52 weeks reduces hepatic fat content in MASLD patients without diabetes mellitus, together with reduction in fasting glucose and anthropometric parameters such as body weight and waist circumference. In the same line, this study also looked at sodium glucose cotransporter 2 inhibitors and the risk of liver cancer and hepatic decompensation. This is in patients with diabetes mellitus. Epidemiological data on the use of SGLT2 inhibitors and hepatocellular carcinoma are limited. So the authors aim to investigate the association with HCC and hepatic decompensation. They did a retrospective cohort study of all adult patients with a newly diagnosed type 2 diabetes mellitus based on a territory-wide electronic healthcare database in Hong Kong between 2000 and 2014. Primary outcome was development of HCC. Secondary outcome was hepatic decompensation, defined as recurrence of ascites, variceal bleeding, hepatic encephalopathy, and /or hepatorenal syndrome. Primary exposure was SGLT2 use, defined as medication use within 6 months from the index date, and was treated as a time-varying variable by identifying drug use at each yearly interval of follow-up to address potential immortal time bias. They had almost 272,000 eligible subjects, 53% were males, so about 12.5% used SGLT2. Median follow-up was 11.7 years. 2,737 and 4,901 cases of liver cancer and hepatic decompensation were identified. Adjusted hazard ratio of liver cancer with SGLT2 use was 0.69, statistically significant. Adjusted hazard ratio of hepatic decompensation was 0.50, again statistically significant. To conclude, SGLT2 inhibitor use was associated with a lower risk of liver cancer and hepatic decompensation with a dose-response relationship among type 2 diabetes mellitus patients. And we will move on to viral hepatitis. The long-term efficacy of tenofovir alafenamide in chronic hepatitis B treated patients for up to 8 years in 2 phase 3 studies. In 2 double-blind randomized phase 3 studies, tenofovir alafenamide has demonstrated non-inferior efficacy related to tenofovir disoproxil in the blinded assessments. After completing up to 3 years of double-blind treatment, all patients were eligible to receive open-label TAF through week 384 or year 8. Efficacy was assessed for each study with the serial assessments for viral suppression, hepatitis B viral load, normalization of ALT, serologic responses, and fibrosis change by serum fibro test. Resistance analysis for those with virologic breakthrough, persistent viremia, or treatment discontinuation with the viremia were performed, as was phenotypic phenotyping of qualifying samples. Of 1298 randomized and treated patients, 1157 entered the open label phase. Overall, 75% of the participants completed open label study treatment. Similarly, high rates of virologic suppression and ALT normalization were achieved and maintained over 8 years in all treatment groups. Sequence and phenotypic analysis through 6 years showed no resistance to TAF. Resistance analysis at either 8 years or ongoing. To conclude, after 8 years of treatment with tenofovir alafenamide, or up to 6 years after switching from tenofovir disoproxil, virologic suppression rates remained high across all groups. Up to 33% of patients achieved hepatitis B E antigen, E antibody seroconversion. However, the hepatitis B surface antigen loss remains low, less than or equal to 5%. Another interesting abstract on the long-term effects of hepatitis B surface antigen clearance, relapse, and safety of tenofovir and entecavir cessation in non-cirrhotic hepatitis B E antigen negative chronic hepatitis B patients. Recent studies have found that stopping nucleotide analogs will lead to more rapid hepatitis B surface antigen clearance. However, only a few studies reported long-term outcomes after discontinuation. The study aimed to evaluate hepatitis B surface antigen loss, virologic response, clinical relapse, and safety after cessation of tenofovir and entecavir discontinuation. 98 non-cirrhotic hepatitis B E antigen negative patients treated with either tenofovir disoproxil or entecavir for at least 3 years and virally suppressed were enrolled into tenofovir discontinued and entecavir discontinued groups and compared to a continued group. All patients were followed for at least 1 year and up to 4 years following NA discontinuation. Of the 98 patients, mean age was 60, 66% were males, median follow-up was 146 weeks. 10.6% achieved hepatitis B surface antigen clearance in the NA group. Cumulative incidence of relapse at week 48, 96, and 144 were, however, 66.9%, 71.6%, and 83% in the tenofovir discontinued group, and 40%, 56% in the entecavir discontinued group, respectively. Cumulative incidence of clinical relapse at weeks 48, 96, and 144 were 39%, 46%, and 50% in the tenofovir group, 22%, 26% in the entecavir group. 6 patients in the tenofovir discontinued group had severe flares of ALT, 2 required admission, and 1 died. To conclude, cessation of tenofovir or entecavir led to achieving hepatitis B surface antigen clearance rate more than continued group, usually in the first year. However, it also increased the risk of virologic relapse and clinical relapse, especially in the tenofovir group. Some patients had early and more severe clinical relapse, which led to hepatic decompensation and death. Next abstract is on the seroconversion rate after 3 doses of HepliSav-B as compared to 2 doses in patients with liver disease. It's an open-label randomized control study. HepliSav-B vaccine was approved by the FDA in 2017 for prevention of hepatitis B. The vaccine uses a synthetic cytosine phosphoguanine oligonucleotide derived from bacterial DNA to stimulate the immune system through the activation of Toll-like receptor 9 pathway. The 2 doses, day 0 and 1 month after vaccine regimen, has been shown to induce higher immunity in healthy individuals compared to the 3-dose conventional vaccine regimen. However, the vaccine response rates are variable and suboptimal in immunocompromised patients. In fact, only 45% of patients with cirrhosis developed immunity after 2 doses of HepliSav-B. So in this ongoing open-label RCT, the authors compared immune responses to 2 doses versus 3 doses of HepliSav-B in vaccine-naive liver disease patients stratified by the presence or absence of cirrhosis. Good responders were defined as having hepatitis B surface antibody titers greater than or equal to 100 international unit per ml. To date, 110 patients have completed the study. 59 patients received 2 doses, 51 received 3 doses. 75% patients in the 2-dose group versus 92% patients in the 3-dose group had a good response, statistically significant. In those with cirrhosis, 68% of the 2-dose group versus 89% in the 3-dose group had a good response. The corresponding numbers in those without cirrhosis was 78% versus 94%. No adverse events were noted. To conclude, in this randomized controlled trial, 3 doses of Heplisav-B appeared to give better immune response rates than 2 doses in those with chronic liver disease. The next 2 abstracts are extremely important. This is on hepatitis B virus reactivation in cancer patients receiving chemotherapy. First one is a systematic review and meta-analysis. As we know, hepatitis B reactivation is a critical concern for cancer patients undergoing chemotherapy. This study aimed to investigate the rate of reactivation of hepatitis B among patients undergoing chemotherapy worldwide. Systematic review and meta-analysis was performed by searching through multiple databases for studies reporting reactivation rate. Random effects model was used to determine the pooled reactivation rate of hepatitis B in cancer patients undergoing chemotherapy. 86 studies representing almost 21,000 patients were analyzed. 62 studies were from Eastern region, 24 studies were from the Western region. Pooled hepatitis B reactivation rate for cancer patients undergoing chemotherapy is 9%, ranging from 7% to 13%. Pooled reactivation rate among patients receiving rituximab-containing regimens was higher than those receiving chemotherapy without rituximab, 9% versus 5%. Hepatitis B reactivation rates for patients who received prophylactic tenofovir was 1%, and for entecavir was also 1%. Pooled reactivation rates for lamivudine and telbivudine were 4% and 6% respectively. To conclude, administering antiviral prophylaxis to cancer patients undergoing chemotherapy has been shown to reduce the risk of hepatitis B reactivation, consequently enhancing the efficacy of anti-cancer treatment and improving patient survival. The last abstract is to try to determine what is the screening rate in cancer patients for hepatitis B before receiving chemotherapy. So we just learned that screening for hepatitis B infection before systemic chemotherapy is essential to identify patients who need antiviral prophylaxis. So the authors examined the hepatitis B screening rate before undergoing chemotherapy. Again, they did a systematic review and meta-analysis. The pooled screening rate was estimated using random effects model. They also performed a subgroup analysis based on the hepatitis B endemic regions, type of malignancy, and chemotherapy regimens. This meta-analysis included 29 studies published between 2010 and 2021. The overall screening rate was just 56%. The screening rates for low, intermediate, and high endemic regions was 42%, 74%, and 64% respectively. Patients with hematological malignancies displayed a higher screening rate of 67% than those with solid organ tumors, 36%. They found that the screening rate was highest in Japan at 84%, in the US it was 34%, and China was 26%. To conclude, despite existing guidelines, pre-chemotherapy hepatitis B screening rate remains unsatisfactory with substantial heterogeneous rates globally. These findings highlight the need for effective strategies to align practices with clinical guidelines. To summarize the results of the abstracts, in an open-label phase 3 study of patients with PBC, seladelpar resulted in significant improvement in ALP, normalization of ALP with an excellent safety profile. Similarly, in patients with PBC, the 12-week course of combination with obeticholic acid and bezafibrate resulted in an improvement in metabolic parameters such as cholesterol, HDL, and LDL, as well as an improvement in alkaline phosphatase. In patients with PBC, obeticholic acid leads to significant improvement in not just alkaline phosphatase, but also in ALT and AST as compared to placebo. So for PBC, our goal should be to try to achieve normalization of alkaline phosphatase. And we have medications now, and there are medications coming up which would help achieve this. GLP-1 agonists have been associated with a significant decline in the risk of hepatic decompensation and liver cancer in MASLD patients in a retrospective cohort. Empagliflozin has been shown to significantly decrease hepatic steatosis, body weight, and weight circumference as compared to placebo in patients with MASLD without diabetes. Similarly, SGLT2 inhibitors have been associated with a significant decrease in the risk of hepatic decompensation and liver cancer in patients with diabetes. High rates of virologic suppression has been noted in patients with tenofovir alafenamide at 8 years after initiation and after 6 years after conversion from TDF to TAF. Discontinuation of hepatitis B antiviral therapy increases the chance of hepatitis B surface antigen clearance, but also increases the risk of severe clinical relapses, which can lead to hepatic decompensation and death. Antiviral therapy significantly decreases the rate of reactivation of hepatitis B in patients receiving chemotherapy. Rates of screening for hepatitis B prior to initiation of chemotherapy remains low despite this risk of hepatitis B reactivation. 3 doses of Heplisab B seems to be superior to 2 doses in achieving good immunologic response in patients with chronic liver disease. Thank you.
So we're only as good as the people who are our colleagues at work. So I want to thank Dr. Bang, Dr. Covelli, Dr. Murali, and Dr. Agarwal for spending this evening selecting the abstracts and presenting this for this group. I also want to thank our colleagues from Orlando. They are all our referring doctors and most importantly, our very good friends. They support our practice, our educational events, and they are our extended family. And without them, we will not be having this event or our practice. I'm so grateful that you decided to spend this weekend with us. I also want to thank our international audience. I've looked at the countries. There's Dr. Naidu from South Africa, many from South Korea, Japan, India, Italy, Australia, Israel, and Taiwan and Thailand, and and Japan. Thank you so much for spending this evening. I know it's way beyond midnight, that you take the time to go online and spend the entire evening into the early hours of the morning means a lot. And I hope you really find this educational event useful. I also want to thank Medtronic and Omega Imaging for sponsoring this program. We can't do good educational events without the support of industry. And once again, thank you. And finally, my thanks to Girish Mishra. He's a very, very good personal friend and a professional colleague who spends a Memorial Day weekend in Orlando just to moderate and have a good time with us and enjoy it. And most importantly, be very gracious and dwell into areas that is not even in his area of expertise. So thanks for it. And I hope we'll have a good dinner. And those of you overseas should go to sleep. Thank you.